welcome to the Spatz Medical Webinar Series. I'm Christe, your host and the Executive Vice President of Sales. I'm excited to kick off today's discussion, which focuses on identifying ideal candidates for endobariatric procedures. This is an exciting topic. Not only is it exciting, but it's a dynamic, evolving field. Selecting the right patients is critical to your success in achieving optimal outcomes to drive that ultimate success for your patients. We're going to share insights today to help you confidently identify and support candidates who are best suited for endobariatric procedures. So who's the right candidate? Well, let's find out. It's my pleasure to introduce our experts leading today's discussion. First, we have Dr. Alexander Shapsis. He is nationally recognized gastroenterologist with over 20 years experience, triple board certified in internal medicine, gastroenterology, and obesity medicine. Based out of Brooklyn, New York, he specializes in advanced weight loss procedures. He is widely respected for his expertise and dedication to his patients, he helped lose weight by implementing innovative and effective procedures. Joining him is Dr. Jeffrey Brooks, the founder of Spatz Medical and creator of Spatz3 Adjustable Balloon system. He is a renowned gastroenterologist with over 20 years experience in non-surgical weight loss. Dr. Brooks is internationally recognized, developing the first and only adjustable intragastric balloon in the world. And he is a published author, respected speaker, regularly shares his knowledge at global conferences focusing on gastrointestinal health and obesity management. Welcome to my physicians today. I'm happy to have you.
Thank you, Chris. Thank you.
Well, let's jump in and get started. The first question I have for you, Dr. Shapsis, is a two-part question. What characteristics define an ideal candidate for endobariatric procedures like the Spatz3? And how do you handle patients with borderline BMI?
Great question, and thank you for bringing me on. First and foremost, I'd like to state that the way I think of it is that the ideal candidate is the candidate who obviously has overweight and obesity, as well as has the willingness to undergo the procedure. Everything starts with recognizing that one is afflicted by a disease state that's called obesity or overweight. Now, what is that? That is chronic, progressive, and relapsing illness. And that is how it has to be recognized. And unfortunately, the majority of patients and physicians don't recognize that to this date still. So if we talk about Spatz3 specifically, most of the intragastric balloons were FDA approved to treat obesity and overweight, starting at body mass index of 27 up to 40. Now, those are stringent criteria, and we're going to talk about BMI as an okay predictor of having this illness. Having said that, somebody who, for example, works out all day long, has a huge body mass of or BMI of over 40, say 50, but that person happens to be a bodybuilder, obviously that's not a person afflicted by obesity, right? So we cannot just go strictly by body mass index. In fact, there are many, many other ways of recognizing whether a person is excellently suited for this procedure. And so I, in my bariatric endoscopy practice and obesity medicine practice, use multitude of measurements. Waist circumference, body composition analysis is one of the key factors that would actually determine whether a person would be the right, well-suited for a bariatric procedure, whether it's surgery, whether it's medications, or endoscopic procedures such as Spatz3. And so a lot goes into selection of the patient. But first and foremost, patient has to be willing to accept the procedure. The patient has to be willing to understand that he or she is afflicted by this problem, and then everything stems from there.
Yes. How do you handle patients with borderline BMI? So our FDA approval in the States is between 30 and 40 BMI. If you have a patient that comes to you that's borderline on either end of the spectrum, how would you handle that?
First of all, I don't refuse any patients. Everything begins with a consultation, and it's important to understand that just because somebody fits within the criteria, what doesn't fit within that body mass index criteria. A lot more goes into it. And again, it's extremely important to understand the nature of the patient's problem. And patients, for example, with body mass index under 30, do we refuse them if they're willing to undergo a procedure? Well, we need to understand that they are afflicted by a problem if, for example, their neck or waist circumference fits the criteria, does that qualify or disqualify them from it? So I really approach this problem in a holistic way. I will not turn a patient who wishes to undergo a specific procedure. If, for example, somebody comes in with a body mass index of 28, and this is a true story, a woman who has had a child a year prior. She's had, in fact, 2 pregnancies. Both of them were afflicted by gestational diabetes. Her hemoglobin A1C is already in the pre-diabetic range, but her body mass index is 28. Now, does that disqualify her from having this procedure? In fact, this patient probably has one of the highest risks of developing diabetes, of developing insulin resistance, already on the way to that. So this is the way for us physicians to really come in and be able to change the trajectory of an impending disease. And so this would be actually a patient who I would recommend to undergo a treatment of choice. And I usually leave the choice. We present choices to the patients between various bariatric endoscopic techniques or medications. And I don't think that there's a wrong one, because whichever choice is acceptable to the patient would be the right one, because doing something about the weight is better than doing absolutely nothing. So these patients are welcome. And I have had a number of patients whose body mass indices were far greater than 40 or even 50 for that matter. Frequently enough, I use bariatric endoscopy and intragastric balloons as a bridge procedure so that they would be able to lose initial weight and then convert them later to, say, endoscopic sleeve. And this is something that's being practiced. And even though we utilize these tools, which were FDA approved, but we use them for an off-label, and that is perfectly fine. And we get great results, and patient satisfaction is the highest.
Thank you, Dr. Shapsis, for that very broad review. Just one other point that you mentioned so correctly, that the patient has to be really willing to undergo the procedure. And I would just add one little point there, that not only that they're willing to work with the procedure. It's not just a magical treatment. There is no magical treatment. You can't just get a procedure, walk out and say, I'm done. No, it's just to be understood that these are, helpful treatments that will help you change your ways. We want you not just to lose weight. We want you to change your eating habits. We want you to approach food differently. And without a balloon, you may not be aware of what you're eating. And that's part of the problem. But when you have a balloon in, you're more aware. You take responsibility for your food. You take action. You change the way you eat. And by the end of your treatment period, you're a different person. So I think if they're willing to go through that journey with us and work with, the ancillary personnel, Dr. Shapsis has a team with him, and patients don't just have the balloon inserted and go home and come back 8 months later. They're visiting Dr. Shapsis either directly or remotely and speaking with his staff and working, through this so that they get the best result.
Thank you, Jeff, for that. And that's a really nice explanation to who the right patient is to consider for endobariatric procedures and really what to look for. On the flip side, what would be some red flags or contraindications that would make a patient unsuitable for a procedure such as the Spatz balloon?
The contraindications as listed are previous gastric surgery, active ulcer disease, peptic ulcer disease, or past disease. In addition to that, blood dyscrasias, problems with coagulation, patients who have recently had any diagnosis of cancer, patients with previous abdominal surgeries and at risk for adhesions or gastric outlet obstruction, patients who are pregnant or actively lactating, those are the patients who should be excluded. Patients with active mental illness, those who cannot follow the directions and obviously express unwillingness to subscribe to the change of their lifestyle or modify their lifestyle. Those probably are the patients who should not undergo those procedures, bariatric endoscopic procedures. For those patients, we reserve other potential treatments.
Yeah, right. So, I had an interesting patient once who was asked, have you had previous stomach surgery? And they said no. we found out later on in the day before we implanted the patient that yes, they did have previous gastric surgery, but like 30 years prior. So they said, well, that doesn't count. I had surgery, it's well healed. It was 30 years ago. Therefore, I don't have to tell the doctor about it. And that's false. Someone who's had a previous gastric surgery, even 50 years ago, is still at much higher risk for developing a gastric perforation with the balloon. So any suture line on the stomach, no matter how long ago, is a contraindication to gastric balloons.
I just wanted to add that I recently had a consultation with another patient who has had multiple lymphoma and received radiation to the stomach. And radiation therapy leaves significant scarring, and that is an absolute contraindication and a potential disaster of a perforation risk as well. So we frequently think of surgery as a contraindication, but radiation therapy to the abdominal area leaves significant scarring in the stomach tissue as well, and that needs to be really catered to and understood.
Yeah,
That's a really important. Good point. Actually, one I'd like to further expand on is ulcers. What are your thoughts on ulcers if a patient has come in displaying an ulcer and wants the Spatz procedure?
Well, first and foremost, we need to understand the nature of the ulcer. More likely than not, the patient most likely will have H. pylori infection. In fact, this is the most common source of an infection, unless they just surreptitiously use non-steroidal anti-inflammatories such as ibuprofen, in which case that's easy enough to treat them for at least 3 months if they don't have H. pylori, to treat them with anti-acid therapy such as proton pump inhibitors, and then rescope them in 3 months and make sure that the ulcer is healed, and make sure that the patient does not, in fact, take any anti-steroidals going forward. With Helicobacter pylori, treatment is important, and I make it an instrumentally important point in my office that every patient will undergo H. pylori testing, not necessarily through endoscopy, but a simple breath test or a fecal antigen test will demonstrate that. And if they in fact test positive, which many of them have in my neck of the woods, they were treated. We made certain that the patient's treatment worked, and we had confirmation by urine breath test, and then they successfully were able to undergo the bariatric endoscopic procedures.
Excellent. Well, thank you.
Yeah, I think the point is that even if you had a previous ulcer, if we demonstrate that it has completely healed, just having a previous history of an ulcer at some point, but now is completely healed, is not a problem.
Great. Yeah. Excellent. Thank you for that. So you touched on this just a little bit of the willingness of the patient, and that Spatz is really looked at as a tool to aid in the weight loss through the journey. So Dr. Shapsis, can you speak to the role of psychology and emotional readiness that you look for in a patient when you're doing a consult for them for an endobariatric procedure?
Most definitely. We look for emotional stability, for willingness to undergo these procedures, understanding of what these procedures are being done for and what's involved in this. In fact, I will recite the patients back to me exactly what the procedure is being done for, what's going to happen, what's entailed, and moreover, the patients sign a sort of a contract with me stating that they are in fact willing to undergo whatever is necessary to make sure that they succeed with bariatric endoscopic procedures such as Spatz3. And frequently enough, patients who don't demonstrate willingness, who concomitantly, and we screen for that actively, show any presence of anorexia or bulimia, which by the way concomitantly exists with obesity, or patients who are actively being treated for any psychiatric illnesses, we either get clearances from their psychologists or psychiatrists, or we simply state that this procedure might not be for them. It has to be very carefully looked at.
So education plays a big role in your process, is what it sounds like. So you have just kind of that verbal contract of understanding of the commitment required, is what it sounds like.
Not only verbal, but a signed contract.
I love it. What are the misconceptions patients have about endobariatric procedures, and how do you address those with your patients?
So frequently enough, we will get a consultant or a prospective patient who thinks that this procedure is kind of a one-time deal. To Jeff's point, that we persuade them otherwise, we inform them, because many a times patients hear these brief bits and pieces of information about what bariatric endoscopy is and what intragastric balloons do, but they have no idea that it's just more than placement of the balloon and then taking it out, because many people think that this is a magic wand, which it isn't. It really is merely as a tool that will allow them to change their behavioral patterns and allow them to change the trajectory of their disease. And so information is key. Having a patient present for a consultation either in person or via telehealth is key, because then we explain to them exactly what the procedure is and what they should realistically expect from it.
Excellent. One of the misconceptions that I often hear in conversation is that the balloon just takes up space in the stomach, and that's how it works. And really, it does indeed take up space, but it also has this delayed stomach emptying, which is important in their post-care journey. And I think that really comes into play, as you mentioned, with education and kind of setting the stage for expectations on how to, as Jeff said it, utilize the balloon as a tool to aid in their weight loss. So I think that's an interesting point that really needs to be rung home with the patients as well. How do you handle patients that are interested in the procedure, but may not be ready to make lifestyle changes?
So it's very important to speak with them about the disease state that they're living through, right? It's the obesity and the overweight. And in my clinical experience, once the patient understands that he or she is afflicted by overweight or obesity as a chronic, progressive, and relapsing illness, I really see a change in an adaptability of the mentality of the subscription of the life to the lifestyle modification. It's extremely important to really have a full-on conversation with these patients. It's also important to simply, other than informing them, to basically give them time. It's important for them to think about that. Some patients are already coming in asking specifically for Spatz3, and we're happy to deliver that after having a conversation with them. Some just need a little bit more time to understand and to embrace the concept of the lifestyle modification that comes along with any tool, no matter whether they undergo surgery, whether they undergo endoscopic sleeves, whether they undergo a Spatz3 or medications for that matter.
You know, I've seen patients along the way who entered with the right attitude and then unfortunately fell off the wagon along the way. And interestingly, there's enough time to go back and do it correctly. So I've seen patients, you know, who lose weight and then they say, well, it's not stopping me from eating completely. I thought it would be better. And they start to regain weight. And you explain to them again that this is a tool and it helps you, you know, be more aware of the food you're eating. It does not stop you like a gun to your head. And they start to understand a little bit. And sometimes by month 4, they say, you know, you're right. And they get back on the wagon and they lose weight beautifully. I've seen that happen several times. And then there are people who just get you know, they have their balloon, they lose less than what, you know, they were hoping to lose, but they come back 4 or 6 months later with a better attitude and they get a second balloon and then they really do well because then they understood that they didn't do it correctly the first time. And that's okay. It's, you know, it's important to know which procedures are really repeatable. Well, balloons are repeatable. And that's one of the really important, you know, attributes of a balloon compared to other treatments.
Jeff, let's not forget about the fact that this is an adjustable balloon. So they may not, in fact, need a second win, if you will, or a second balloon, correct, if within the 8 months period here in the States, they actually have stagnation and we can adjust that. And that's kind of important.
Absolutely.
Thank you for those points. So we touched a lot about who the right patient is, the mindset, the emotional readiness for the procedure. Can you share insights on post-procedure follow-up and the role that plays in maintaining your patient outcomes?
That is one of the most important things. So even though the procedure takes about 15 minutes to perform, it is the aftercare where the key to success lies, at least in my practice. And I'll just walk you through the steps. So first and foremost, upon awakening, immediately after the procedure, I will make sure that every patient and their loved one, because everyone has to have someone who comes in as a caretaker, they both are re-informed on the next step. So it's extremely important for these patients to be on clear liquid diet and then on a protein liquid diet until the progression into the soft diet and all the way through the time when they have to go back on a solid diet. Every patient will be seen within 24 hours in my office, and each and every one of them will receive intravenous hydration. I think the earlier studies have shown that the balloon intolerance early on, or some of the side effects, such as nausea and vomiting, they're very much preventable. What is the number one prevention? It's not the medication, it's dehydration prevention. So we make sure that every patient will receive intravenous fluids, and then thereafter, they will be followed up by an app, and we have an app that we use, and every patient will get their own biometric scale. And that is the quickest way of communicating with me, and also a way for me to monitor them remotely on a daily basis. If there's anything that I've seen in my practice that really has transformed the patient's results, it's if within the first 2 to 4 weeks, patients subscribe to the mentality of daily weights. So they have to weigh themselves on a daily basis. That biometric data is transported to essentially to my app, to my office, where I'm able to monitor how the patients are doing. So this sort of remote monitoring has been the key to the success that we've seen at Endoslim Clinic. In addition, every patient will have a follow-up routinely and regularly. In fact, through the time that I've been doing bariatric endoscopy, patients who have come back for follow-ups, regularly scheduled follow-ups, who have responded to my messages, are the ones that actually will do very, very well. We've had a few of those that Jeff has mentioned before that sort of fall off the curve. They sort of give up, they stop communicating. Those are the ones that are less likely to do well, all right? And so it's important to monitor the patients. It's important to intervene early into their stagnation or weight regains throughout the process, because we can actually do something about that. We can actually intervene and put them on the path of success again. It's the high fives, it's the frequent communication, it's the positive reinforcement, and sort of going back and forth and reminding really them why is it that they did it in the first place. That works the best.
And that's important that you choose the right doctor to do this procedure. You know, Dr. Shapsis has his staff, and he has his follow-up carefully laid out. It's all available, and you have to make sure that your doctor or your clinic is offering that. That's the difference between a successful clinic and an unsuccessful clinic and successful patients.
Well said. So my last question, save the best for last. What advice do you have for other physicians looking to get into and to start to implement endobariatric procedures in their practice?
Love thy craft. Well, I personally invest myself into every patient, and I tell my patient that I shed a pound with them, with each and every one of them. And so you have to sort of devote yourself to these patients. They do require a lot of tender loving care, and they do very well if you invest them and if they feel that you believe in their success. On top of everything else, so we can train a lot of physicians. Just about any endoscopist nowadays would be able to place a balloon and extract a balloon. That's the easy part, right? That's the technical component. Anybody and everybody can learn that. It doesn't take that long, and anybody who's ever held an endoscope in their hands would be able to do it. It's the magic that happens afterwards that really will transform that. First and foremost, my colleagues need to understand obesity as a disease state, what happens to the patient, and then metabolic level, endocrine level, level of muscle mass and transformation of fatty acids. It's very, very important, as well as on a psychological level. So being boarded in obesity medicine has really transformed my understanding of the obesity as a disease. It really has allowed me to reinvent myself really within the realm of gastroenterology, and really start and begin to offer excellent results to all of my patients. And so if anybody among my both metabolic and bariatric surgical physicians and endoscopists really, if anybody really wanted to get into bariatric endoscopy and balloons, they can, but you have to understand that you are putting yourself out there for your patients. Every single one of my patients has direct contact to me. Yes, I am able to respond to every one of them. From time to time, we will get calls about different issues, whether it's nausea, whether it's vomiting, whether it's constipation. All of these are well-known phenomena that by now we know how to handle, but you have to be willing to put yourself out there for them. And if you are willing to do that, I think you're going to have great success.
Amazing. Well, I appreciate that. Thank you so much, Dr. Shapsis, for your time, and Dr. Brooks, your insight, your expertise in helping us identify ideal candidates for endobariatric procedures was extremely helpful to hear from both of you today. So I appreciate your time, and thank you for joining.
Thanks for having me.
Christe.
Bye.